have attempted to make this clinically relevant. Now, you may wonder, who cares? Well, you should care because, first of all, there are now a number of drugs on the market that target specifically these transporters, and you need to know a little bit about what they're doing to be able to predict the benefit and some of the problems that the patients are going to have. And the second thing is this sort of stuff really doesn't feel on boards. Okay, so I'm going to start off with talking about sodium. Well, sodium ions are mainly in the extravascular fluid compartment. You know, serum sodium is going to be around 140, but if you measure intracellular sodium, it's only going to be on the order of about 10 to 20 milliequivalents per liter. So intracellular sodium concentration is much lower than extracellular sodium concentration by about an order of magnitude. And in most cells, now this is not 100% true, but in most cells, sodium movement is driven by the concentration gradient that's set up by the sodium-potassium ATPase. So the sodium pump eliminates sodium from the intracellular space, which then is what generates a low level of, intracellular sodium, and that then provides a driving force for sodium uptake through a lot of the transporters that we're going to be talking about today. The control of extracellular fluid volume is dependent upon the regulation of sodium balance, so the sodium that we take in, like in the diet, in addition to the sodium we put out in the urine and the stool and the sweat. And it's this balance is determined by the relationship between sodium intake and extrarenal sodium loss and renal sodium excretion. So along the nephron, sodium is filtered at the level of the glomerulus. About 50 to 75% of sodium that's filtered is absorbed in the proximal tubule. About 25 to 30% is absorbed at the level of the loop of Henle. And then at the level of the collecting duct, only about 5% is absorbed. But this is very important for the final regulation in sodium balance. So I'm going to talk first about this proximal tubule. As I mentioned, the uptake of sodium through all of these transporters is driven by the low level of intracellular sodium. And that, in turn, is generated by the active transport that's provided by the sodium-potassium ATPase. So sodium is transported out of the cell through the sodium pump, which in the process consumes sodium, or consumes ATP. That then generates a very low level of intracellular sodium, which provides the driving force for sodium uptake just down its concentration gradient through these three transporters. We're going to talk about first the sodium glucose cotransporters, and the important isoforms are type 1 and type 2. That is a electroneutral sodium glucose cotransporter. And this is really a great study. Just during the time in my career, I was a postdoc fellow like you all back at UCLA, and at that time, Ernie Wright was just studying the transport mechanisms of the sodium glucose cotransporter. He then went on to clone the gene for these things, and once you clone the genes, you can do all kinds. You can generate a bunch of tools, which really allow you to study the transporter well. And so, if you clone the gene, then you can develop antibodies. You can develop knockout mice. You can develop primers for study of PCR. And on the basis of that study, we now have drugs which effectively transport that study. So it's really a great story of bench-to-bedside research. And one of the reasons, the beauty of the kidney and why so many kidney genes have been cloned and why there's so many drugs that affect transporters in the kidney are now available is because the transport mechanisms in the kidney were pretty well studied about 30 years ago. So that made it then easier for people to clone the genes because they knew what to look for in heterologous expression system. And then once the genes were cloned, then the drugs were available. So I think here we, meaning the nephrology community, needs to really pat themselves on the back and in terms of what a great job we've done in defining the transport properties of these different transporters along the nephron. So S-glut 1 and 2 I'm going to talk about first. So sodium glucose reabsorption. Glucose is absorbed along the nephron with sodium, mainly in the proximal tubule. And within the proximal tubule, most of the glucose is absorbed in the very early part, or the S1 segment of the proximal tubule. And glucose is typical of substances removed from the urine by secondary active transport. So in other words, it's what we talked about. The sodium pump here generates the driving force, which then provides the driving force for the absorption of sodium, and then it's coupled glucose absorption. Almost, in normal people, almost all filtered glucose is absorbed. And so in a normal person, only a few milligrams of glucose are excreted in 24 hours. Of course, that's much different in diabetes. So the amount of the absorbed glucose is proportional to the amount that's filtered, and then hence to the plasma glucose concentration times the GFR up to a transport maximum. So glucose absorption is transport limited. It absorbs everything up to a certain level, and then after that level, you dump it all out in your urine. So when the transport maximum is exceeded, glucose appears in the urine. And so the transport maximum is about 375 milligrams per minute in men and about 300 in women. So what happens here is shown in this slide. You absorb everything that's filtered, all the glucose that's filtered up to a certain threshold, and that's about 300. And at that level, you still get the same amount of glucose that's reabsorbed, but that in excess is excreted in the urine. So the renal threshold for glucose at the for glucose is the plasma level at which glucose first appears in the urine. So the renal threshold should be about 300 milligrams per deciliter, or 375 milligrams per minute divided by the GFR. But in reality, it's only about 200. So when plasma glucose level exceeds about 180 milligrams per deciliter, you get glucosuria. So S-glut 2, that is the main target of the therapeutics we use now in renal practice that target sodium glucose cotransport in the proximal tubule. It's in the S1 segment of the proximal tubule, so the very most proximal part of the proximal tubule. It's a high capacity, low affinity transporter. So in other words, it holds a lot of glucose. It transports sodium and glucose in a one-to-one relationship. So one sodium is transported for every one glucose, and it absorbs about 90% of the glucose filtered at the glomerulus under normal conditions. In other words, a non-diabetic. S-glut 1 localizes to the more distal parts of the proximal tubule. It also localizes to gut, in particular the duodenum. So with the drugs that are available now, which are thought to target S-glut 2, they actually hit this one as well to some degree. So you can get some GI side effects, and that's because of its effect in the gut. So this is, in contrast to S-glut 2, this is a high affinity, low capacity transporter. And in contrast to S-glut 2, it transports sodium and glucose in a 2-to-1 relationship. So it transports 2 sodiums for every 1 glucose. And in normal people, it absorbs about 10% of the filtered glucose. So these are the sodium glucose cotransport inhibitors that are available now commercially. Any of you guys used them? Mm-hmm. Okay, you like them?
Women get like UTIs a lot.
Oh, well, I'm coming to the UTI bit. Don't steal my thunder. Okay, anything else you don't like about them?
No.
Other than the UTIs, it's good?
Well, they can have normal blood glucose decay, where they have normal blood glucose and they are still decaying. So that's one of the big things about them right now. But they're in decay with normal blood glucose. They're not like presented with 600 or 700. So they're normal glycemic.
Oh, I see what you're saying. Yeah, sure. Well, because you need insulin to treat DKA. So yeah, bring down the blood sugar, but yeah, okay. So what do they do for you? Well, the SG-glut2 inhibitors the therapeutic benefits relative to placebo, they do reduce hemoglobin A1C. They reduce fasting blood sugar, as you mentioned. They reduce systolic blood pressure by about 5 millimeters of mercury, and that's at least in part because you block sodium uptake, because you block the sodium glucose transport mechanism. So you get a bit of a natriuresis. And then you also lose a body weight, and that's due to some loss of fat in addition to the natriuresis. And that's thought to be because of the glucosuria, you're just excreting a big chunk of your calories. So you tend to get a weight loss of about 2 kilos in people on these drugs. They do have some side effects. So they mentioned genital infections and UTIs. You can get hypoglycemia, but that's usually because of some of the drugs that are administered in tandem, like insulin. You can get volume depletion, probably because of the natriuresis, and you should not use them with bladder cancer. I don't think anybody knows what the mechanism is here. And you also should not use them with renal insufficiency. Okay, so the next one I'm going to talk about is a sodium phosphate cotransporter, SNAPI2A and 2C. And so they transport sodium coupled with phosphate, another good proximal tubule transporter. So NAPI2A is actually by far and away the better studied of these two isoforms. And the reason is because it's highly expressed in mice. And in mice, most phosphate absorption in the proximal tubule occurs through NAPI2A. Now that's not true in people. In people, it's NAPI2A and 2C. But it absorbs about 80% of the filtered phosphate in mice, and it moves one of the divalent islands with 3 sodiums or 2 of the monovalents with 2 sodiums. It's highly regulated by parathyroid hormone. So PTH reduces renal phosphate absorption by causing endocytosis of NAPI2A. So you just don't absorb as much sodium. So less sodium phosphate less of the NAPI2A is on the apical plasma membrane, so you just don't absorb as much. I tried to find out if there's any link between the phosphate, parathyroid cinecalcin and NAPI2A or C, and I could not find anything. Anybody know anything about that? Because I tried to do a PubMed search and nothing came out. Somebody should do that. Maybe one of you guys will do that. Look at, just give mice cinecalcin and see what happens to NAPI2A and 2C expression. So I think that'd be a nice project. Well, anyway, no takers here. Okay, so what happens when you knock out NAPI2A in mice? Well, of course, you don't absorb as much phosphate, so you get hypophosphatemia. You get nephrolithiasis, probably because you just dump a lot of phosphate in your urine, and you get osteoporosis. Okay, so what happens in people? If people with NAPI2A gene ablation have been described, it's very rare, it's autosomal recessive, and you get severe renal phosphate wasting, same as a knockout mice. You get hypophosphatemia, same as the mice. You get rickets, which includes osteomalacia, leg deformities, and bone pain. You get vitamin D deficiency. I want you to remember that. You get mild to moderate renal failure, probably because of the nephrocalcinosis. And you also get Fanconi syndrome. So you get amino aciduria, glucosuria, and proteinuria.
How do you get vitamin D deficiency?
Yeah.
That should be
The opposite.
I know. I don't know. I do not know. But that's a good question. I don't know. Anybody know? I don't know. Now, NAPI2C, once again, this is expressed in low levels in mice, so it's really not as well understood at the basic science level, but it's important in people. And people with NAPI2C gene ablation have been described, and once again, it's rare, it's autosomal recessive. They get hypercalciuria, and they also get phosphaturia and hypophosphatemia, the same as the NAPI2A, and they also get rickets. But the difference there is that actually vitamin D is increased. So why you get increased vitamin D with one and not the other, I do not know.
I thought rickets was vitamin D
Yeah, but with the
That's amazing.
2A, you get the same
Oh.
feeling. Pardon? Yeah, I think it has to do with the hypophosphatemia.
Okay.
And so you probably just don't get the bone mineralization. Anybody else know anything about that? I'm not an expert on
So like having
phosphate.
the vitamin D being high didn't make a difference, basically, in the bone mineral.
Evidently not. I think it probably has to do with the fact that you just can't hang on to phosphate. And so
Okay.
that component of, that would be my guess, that component
Okay.
of mineralization is just not there. Anybody else know anything else about that? No? Okay, and the last one is the sodium proton exchanger, sodium NHE3. It's an electroneutral exchanger, so in other words, it exchanges one sodium for one proton in a one-to-one fashion, so you don't generate a current when it does its thing. It exchanges sodium for protons or sodium for ammonium, and it's sensitive to amiloride analogs, but only at high doses. So if you give one of your patients amiloride or benzamyl, which are both amiloride or amiloride analogs, you really don't hit the sodium proton exchanger of the proximal tubule. And the reason is because it's just, you need too much amiloride. You need like millimolar concentrations. And in the luminal fluid, you probably only get micromolar concentration. So when you use amiloride, you target ENaC downstream, which we'll talk about. But the sodium proton exchanger is unscathed for all practical purposes. Okay, so the NHE3 reduces bicarbonate absorption in the proximal tubule by about 50%. When you knock it out, you reduce bicarbonate absorption in the proximal tubule by about 50%. You get a metabolic acidosis, and you also get hypotension. And that is true both in the global and also in the kidney-specific NHE3 knockout mice, and that's probably because of reduced sodium absorption, the natriuresis you get. It's highly regulated by angiotensin II, and it does it by, really there's no change in NHE3 total protein abundance. It regulates the endo and exocytosis of NHE3. So that's a big mechanism of the pressor response that you see with angiotensin II. Now in people, there are no reports of people with NHE3 gene ablation. It's probably embryonic lethal. And similarly, I could not find any NHE3 polymorphisms in people that are associated with changes in blood pressure or a metabolic acidosis or anything like that. Okay, so any questions about the proximal tubule? We're going to go on to the next segment. No questions? Okay. Okay, sodium transport in the loop of Henle. Loop of Henle, very important. It absorbs about 25 to 30% of filtered sodium. And once again, it's also through secondary active transport through the action of sodium, potassium, ATPase. And of course, it's the site of action of our dearly loved loop diuretics, furosemide, bumetanide, and torsemide. So this is how the thick limb works. Sodium is absorbed through NKCC2, the sodium potassium 2 chloride cotransporter, and it absorbs one sodium, one potassium, and 2 chlorides. Now the sodium and the chloride is then absorbed through transepithelial transport and exits along the basolateral membrane through the sodium pump and also through chloride channels. And that sodium absorption then leads to an interstitium that's hypertonic because of increased concentration of sodium chloride, especially in the deep IMCD relative to plasma. So sodium chloride concentration in the tip of the inner medulla goes up to about 300 milliequivalents per liter, which compares to about 140 in plasma. So that contributes to the very hypertonic interstitial fluid in the inner medulla, and it thereby contributes to urinary concentration. But it also, this thing here also contributes to urinary dilution. So you have to keep remembering that the loop of Henle is impermeable to water, but it's very permeable to salt. So as you absorb all of this sodium chloride through NKCC2, the sodium gets absorbed, but the water just hangs around. Got that? Okay, so the sodium chloride concentration at the end of the loop of Henle is low, it's hypotonic. So then this very hypotonic fluid goes through the rest of the nephron, and then in the collecting duct, if there's no vasopressin, it's not going to be absorbed. So you're excreting hypotonic luminal fluid. So this is very important. It's very important for both urinary concentration and also urinary dilution. So if you knock out this, or you inhibit it with one of our beloved loop diuretics, you can neither fully concentrate nor fully dilute your urine. Make sense? But there's more to it than that. So sodium sodium chloride is absorbed in transcellular transport, but potassium is recycled. So potassium comes in and then goes out through ROM-K, forget what that's called. But anyway, in so doing, it generates a lumen positive voltage through this K recycling. And that lumen positive voltage provides the active transport step for calcium and magnesium transport through paracellular transport. And so that's why if you give a patient loop diuretics, you get calciuria, because you eliminate this lumen positive voltage, which provides the driving force for paracellular cation transport like magnesium and calcium. And then you also have NHE3, which is here in the loop of Henle, and that's important for also for sodium absorption and for potassium secretion. So you tend to get a metabolic acidosis if you eliminate this. So any questions about loop of Henle? So the thick ascending limb absorbs sodium but is impermeable to water, and it produces therefore a hypotonic luminal fluid. So in Barter's syndrome, which you get by, you can either get an acquired Barter's by things, certain drugs. You can also have an inherited Barter's, or you can get a Barter's just by giving loop diuretics. So if you have a Barter's syndrome, you can get the same phenotype with genetic ablation of that, either NKCC2, ROM-K, or this basolateral chloride channel. So you get the same symptoms, whether or not you knock out this, or this. However, when you give loop diuretics, you specifically target that, but then in so doing, screw up all these other transport mechanisms since they all work together. Okay, so you get Barter's syndrome, which is phenotypically indistinguishable if you knock out this, or this. So what happens when a patient has Barter's syndrome, or if you give them a loop diuretic? Well, you get salt wasting, you get hypokalemia, you get a metabolic alkalosis. The alkalosis is probably because their volume contracted and you stimulate the release of aldosterone. And then you get a defect in urinary concentration and dilution. Okay, the distal convoluted tubule. So the distal convoluted tubule, it's in the aldosterone sensitive region of the nephron right here. And the main thing it has to do in terms of tubule transport is the sodium chloride cotransporter, NKCC, which is thiazide sensitive. So the sodium chloride cotransporter, the distal convoluted tubule shown here, mediates electroneutral sodium absorption, and it's highly regulated by the mineralocorticoid receptor. And so the way that happens is aldosterone binds to the MR, that then targets the nucleus. It also stimulates another bunch of downstream signaling pathways, which increase the transcription of NCC mRNA, which translates into increased NCC protein. And then through these other signaling mechanisms that are upregulated, it's trafficked to the epithelial membrane. So you knock out NCC with thiazides, like diuryl and hydrochlorothiazide, and that directly targets NCC. You can also target NCC by mineralocorticoid antagonists like clarinone or spironolactone. And finally, the cortical collecting duct, or the collecting duct, we're going to talk mainly about the CCD. It absorbs 5 to 7% of filtered sodium, and at least in the cortical collecting duct, most sodium is absorbed by the epithelial sodium channel, ENaC. So, for sodium to be absorbed through ENaC, there are really two things that have to be created. First of all, you need a concentration gradient. In other words, the sodium concentration outside the cells, inside the cells, got to be less than the sodium in the luminal fluid. You've got to have a gradient. And that gradient is generated by the action of the sodium-potassium ATPase. And that is shown in this slide. So through the action of the sodium pump, intracellular sodium falls, which then increases the gradient from the luminal fluid to the cell, so that sodium can be absorbed through the epithelial sodium channel. But the other thing that has to be present is that the cell has to be permeable, the apical membrane has to be permeable to sodium. So that requires two things. First of all, the channel has to be open. If it's closed, it's not going to absorb any sodium. And then you have to have the ENaC protein on the apical plasma membrane. So you have to have an N, or a number of active channels on the apical membrane. So the channel has to be open, and the channel has to be functional and present at the level of the apical plasma membrane. So, once again, sodium is absorbed through the epithelial sodium channel, and down through both active channels on the apical plasma membrane, through channels that are open, and across a concentration gradient. So sodium absorption in the cortical collecting duct occurs primarily through ENaC. ENaC is stimulated by aldosterone, mineralocorticoid, also aldo and cortisol, and also by vasopressin, which we won't talk about too much. ENaC is blocked with amiloride analogs, with mineralocorticoid receptor blockers such as spironolactone or clarinone, and through, of course, sodium-potassium ATPase inhibitors like wobane, which really aren't used much in clinical practice. So the way that works is that the sodium aldosterone binds the mineralocorticoid receptor. That then stimulates both the amount of the sodium pump and the amount of the epithelial sodium channel. It also stimulates the action of the sodium-potassium ATPase, which generates a lumen negative voltage, which provides a driving force for secretion of potassium. So potassium just goes down its electrochemical gradient. With a mineralocorticoid antagonist, the MR is blocked, so you get less sodium pump expression and activity, less expression of the sodium-potassium ATPase, that then eliminates the lumen negative voltage, and you don't get so much potassium secretion. So that's why you see a natriuresis and a chloreuresis, as well as reduced kaliuresis with an MR antagonist.
Dr. Ball, along with that, with ENaC, when you when you block that, when you stimulate that, you also get alkalosis, right? So where do you secrete that proton?
Okay. Pardon?
Principal cell.
No, actually, protons
Pendrin,
are,
right?
it goes in the opposite direction. It secretes bicarbonate, so that should make the alkalosis better. So the proton secretion along the collecting duct is mainly through intercalated cells.
Right.
So the thought has been that if you rev up ENaC, you have a more lumen negative voltage,
Right.
and that stimulates proton secretion. And clearly, if you eliminate ENaC, like you give an animal amiloride, you get a metabolic acidosis. But, and they think it's because you eliminate the lumen negative voltage. I actually don't think that's true. What we have found is that you actually stimulate proton secretion if you block ENaC. I think it has more to do with the change in potassium and the effect that potassium has on ammonia. We'll come back to this. But if you're taking a test, then, clearly you get a metabolic acidosis if you block ENaC.
Right.
But how it does that, I don't think is that well understood.
Like when you rev up your renin aldo, you do get a metabolic alkalosis.
Correct.
Right? And that has to do because you have to maintain the electroneutrality of the membrane over there. That's why you have to, with the ROMK, you are secreting out potassium, but at the same time you're also secreting out proton. So where do you secrete out the proton from? Is it the pendrin or the...
No, you secrete protons. Pendrin secretes bicarbonate.
Okay.
So you secrete protons. That's clear. If you give aldo, proton secretion goes up. But what the mechanism is clear. I don't think it has anything to do with the lumen negative voltage that's generated with ENaC. I think it has to do with the fact that if you give aldo, you stimulate, you get hypokalemia. And the hypokalemia stimulates the production and the secretion of ammonia. And I think it's that conversely, if you're hyperkalemic, you reduce ammonia production. So I think it has to do with the ammonia, but it's not very well understood. If you're a Phil Steinmetz disciple, you'll say it's a lumen negative voltage. But I don't quite believe that. Okay, so angiotensin II is very important in sodium absorption along the nephron and the pressor response. And in turn, these sodium transporters are important in the pressor response to angiotensin II. So you target angiotensin II clinically by both targeting angiotensin II production through ACE inhibitors and through the angiotensin type 1A receptor, which are the ARBs. And virtually all of the sodium transporters that we talked about are sensitive to angiotensin II. So when you give a person an ACE or an ARB, you're probably hitting all of these mechanisms. Okay, K transporters, once again in the loop of Henle, you have ROMK. If you knock out ROMK, you get hypokalemia, although I don't think they really understand how that happens. And once again, if you not in Bartter syndrome with loop diuretic administration or with inherited or acquired Barters, you do get hypokalemia. And most of the regulation, however, of potassium secretion and K balance occurs within the connecting tubule and to a lesser degree within the cortical collecting duct. So what's thought to happen, actually it's more complicated than this. Boy, there must be some problem with the computers or something.
Yes.
Okay. So, what's thought to happen is that sodium is absorbed with ENaC. That generates a lumen negative voltage, and that provides the driving force for the secretion of potassium. And it is true that if you eliminate ENaC through either genetic ablation or chemical inhibitor, you do reduce potassium excretion, and that the animal gets was due to a fall in net acid excretion, and the rest was due to the excretion of bicarbonate. So ammonium excretion is very important in acid-base regulation. So how does ammonium reach the final urine? And this goes along with just what we were talking about. Ammonium is synthesized in the proximal tubule from glutamine, and then is therefore secreted into the luminal fluid in part through NHE3. And then it stays in the luminal fluid, and then at the level of the thick ascending limb, ammonium substitutes for potassium on NKCC2. And then it enters the interstitium of the kidney, particularly the interstitium of the inner medulla, where it's concentrated. And so ammonium levels actually are much higher in the interstitium of the inner medulla than they are in serum. So total ammonia concentration can go as high as 10 millimolar in the deep part of the interstitium of the inner medulla, which compares to about 1 millimolar in plasma. So it goes up about 2 orders of magnitude in the interstitium of the inner medulla. And then from there, it is secreted into the luminal fluid of the collecting duct. And it does that in part through passive diffusion of NH3, just down its concentration gradient. Although there is some direct transport of NH4, but I won't go into that. So if you look at the concentration of ammonium here at the most superficial part of the connecting tubule, the total ammonia that's in the urine, only about 20% is here. So the other 80% reaches the luminal fluid by transepithelial transport from the interstitium to the collecting duct lumen. So it's actually very important. So metabolic acidosis is observed when ammonium excretion is inappropriately low. In other words, you just don't dump enough ammonium in the urine, or when you excrete too much base. And so I'll talk about both of these separately. Either because excretion of base is too high or excretion of protons is too low. So metabolic acid absorption is observed when the excretion of bicarbonate is appropriately high or a proton excretion is too low. An example of this is genetic ablation of the proton pump, the proton ATPase. And with genetic ablation of the proton pump, you get a type 1 RTA. And once again, that affects ammonium excretion indirectly because you cannot acidify the urine enough if you knock out the proton pump. So that means of the total ammonia that's present in the interstitium, the NH3 concentration is going to be unchanged here in the interstitium, but of the total ammonia that's present in the luminal fluid, because the pH is higher, relatively less is going to be NH3 and more is going to be NH4, so you're going to reduce this concentration gradient. Remember, ammonium is a base with a pK of 9, so as you reduce the luminal pH, relatively more of the total ammonia is going to be NH4 and less is going to be NH3. So how do protons and ammonia reach the final urine? Well, it's, as I mentioned before, ammonium is synthesized in the proximal tubule. It enters the luminal fluid. It's then absorbed by NKCC2, where it's concentrated in the luminal fluid, and then it reaches the collecting duct lumen and is finally excreted through transepithelial transport between the interstitium and the collecting duct lumen. So you can increase it. This is dependent upon the concentration gradient between here and here, and you can increase this gradient either by increasing ammonium concentration in the interstitium or reducing it in the luminal fluid. And so we're going to talk about each one of those separately. So ammonia is a weak base with a pK of 9. So that means that a pH of 9, NH3 and NH4 concentration is equal. But as you reduce the pH, relatively more of total ammonia is NH4 and relatively less is NH3. So at neutral pH, or a pH of 7.4, only about 1% of total ammonia is NH3 and the other 99% is NH4. So the determinants of increased ammonia secretion along the collecting duct occurs by increasing interstitial NH3 concentration, which you get with countercurrent multiplication through NKCC2, as we talked about. And the second is by luminal NH3 concentration, which is dependent upon luminal acidification. So the more acidic the luminal fluid is, the less the NH3 concentration, which increases the driving force. Conversely, if with increased countercurrent multiplication, you increase the interstitial NH3 concentration, which also increases the concentration gradient from the interstitium to the collecting duct lumen. So once again, NKCC2 generates increased luminal interstitial NH3 concentration by promoting the absorption of sodium and thereby increasing the interstitial concentration of total ammonia, which means more NH4 and more NH3. Oh, and there are also a concentration gradient for interstitial total ammonia concentration. So with the most superficial cortex, interstitial ammonia concentration is about the same as plasma. It's going to be about 1.1 millimolar. But at the papillary tip, under some conditions, it goes as high as about 10 millimolar. So it increases from the superficial cortex to the deep interstitial medulla. And of course, this gradient is greatly influenced by acid-base balance. So this was a study that was done in rats by the NIH group about 30 years ago. And what they did is they took samples of rat tissue from the cortex, from the outer medulla, and from various regions of the inner medulla, the most proximal inner medulla, and then the papillary tip. And then they ground it up, and they measured total tissue ammonia concentration in each one of these zones. And as you can see, the total tissue ammonia concentration is low in the cortex and outer medulla, but then increases as one goes from the inner-outer medullary junction to the papillary tip. And this ammonia content increases in metabolic acidosis, and it decreases in metabolic alkalosis, which is which is appropriate, because you're going to want to increase the interstitial ammonia concentration in metabolic acidosis to increase the driving force for the secretion of ammonia.
And this was just interstitial?
No, it's total tissue, but at least in the inner medulla, that's mainly interstitial. So, the second component, and of course, is luminal acidification. So you increase this gradient by increasing this in the interstitium or reducing this here in the collecting duct lumen. And with luminal acidification, relatively less of the total ammonia is going to be NH3. And remember, pH is a logarithmic function. So if you go from a pH of 6 to 5, you reduce protons by an order of magnitude. This is a study that was done also in the rat by David Good, where he actually sampled interstitial NH3 concentration in the interstitium of the inner medulla, and then sampled fluid in the lumen of the collecting duct at the same level. And as you can see, the interstitial concentration of NH3 was definitely higher in the interstitium than it was in the collecting duct lumen at the same level, which shows that there is in fact a concentration gradient which promotes the secretion of ammonia. And with metabolic acidosis, of course, this gradient increases dramatically. So an example of this deranged excretion of ammonia can be seen with hypokalemia. So with hypokalemia, you markedly increase the production of ammonium that then enters the luminal fluid. But because there is not much potassium in the luminal fluid during hypokalemia, ammonium, but there's a lot of ammonium, the transport of ammonia, which competes with potassium, is greatly increased. So you get a big increase in ammonium concentration in the interstitium of the inner medulla. So the manifestations of hypokalemia are increased total ammonia excretion by the kidney, and you get a metabolic alkalosis because you just dump too much ammonia in the urine. The second way that acid base is regulated is through the excretion of bicarbonate or hydroxyl equivalents in protons. And of course, that is going to impact ammonium excretion, because as you reduce the pH of the luminal fluid, you reduce NH3 concentration, which augments the excretion of ammonium. You get more ammonium excretion, and you help correct the metabolic acidosis. And of course, NH3 is regulated by acid-base balance. So during metabolic alkalosis, bicarbonate absorption by the proximal tubule is reduced. And in the cortical collecting duct, probably the more important thing is that you've got intercalated cells which secrete or absorb proton equivalents. And they're classified as type A, B, or non-A, non-B intercalated cells based on the polarity of the proton pump which predicts whether or not it's going to secrete protons or absorb protons, and the presence or absence of the chloride bicarbonate exchanger AE1. So, in type A intercalated cells, you've got the proton pump on the apical membrane, and that mediates the secretion of protons. And in models of metabolic acidosis, these two mechanisms are greatly upregulated, which increases the secretion of protons. On the other hand, in models of metabolic alkalosis, the type B intercalated cell chloride bicarbonate exchanger is greatly upregulated, which increases the secretion of bicarbonate in exchange for chloride. So type B intercalated cells have a chloride bicarbonate exchanger on the apical membrane. This transporter is thought to be critical in the secretion of bicarbonate equivalents by the kidney during metabolic alkalosis. However, since this is a chloride bicarbonate exchanger, in order to secrete the bicarbonate through this exchanger, you've got to have chloride in the luminal fluid. So, if you don't have any chloride in the luminal fluid, you don't get this chloride bicarbonate exchange, and so this transporter can't really secrete much bicarbonate. So that's one of the reasons why, if you have a patient with metabolic alkalosis, the first test you want to order is a urine chloride. And if it's low, then you have to think that they might have a chloride-sensitive metabolic alkalosis. So with deranged apical anion exchange, or this intercalated cell chloride bicarbonate exchanger, you tend to see it manifested as low urinary chloride, metabolic alkalosis, and the treatment is just a salt infusion. So, talk a bit about the differential diagnosis of metabolic alkalosis. Of course, you can get it with exogenous bicarbonate loads. You can get it of GI origin, like with vomiting, which is going to cause the loss of a lot of proton equivalents. And you can get it with the renal origin, which is either dependent or independent of aldosterone. So exogenous bicarbonate loads, you can get that with the administration of sodium bicarbonate. And the way that works is that bicarbonate titrates protons, it generates carbonic acid, and that then diffuses, it's converted to CO2 and water, which is just lost in the lung. So since pH measures the proton concentration, if you have a proton acceptor like bicarbonate, you're going to reduce the proton concentration in the blood, and what you'll measure is just a reduced urinary pH. Now, I can tell you, people with normal renal function, it's very difficult to generate a significant alkalosis with infusion of sodium bicarbonate. But if they have renal insufficiency or they're chloride depleted, you can do it. You can also get it with milk alkali syndrome, like when patients are taking a lot of Tums, calcium carbonate. And once again, it's through a similar mechanism. You have bicarbonate that titrates protons. Actually, this is carbonate that titrates protons to generate carbonic acid, which is then converted to CO2, which is blown off in the lung and water. So you consume protons if you take in Tums. And then, of course, you can get it from recovery from a lactate or ketoacidosis, since these organic anions are converted ultimately to bicarbonate, which then ultimately titrates protons. So you can get an overshoot alkalosis, and that's why you don't want to overtreat those conditions. So you can get metabolic alkalosis of GI origin from vomiting or NG aspiration, because you lose a lot of protons in the vomitus. And you can also get it from congenital and villus adenoma, and that's because of just chloride loss in the stool. So you get a chloride-sensitive metabolic alkalosis. You can also get it from the effects of aldosterone, independently or, anyway, it can be a renal origin, which is either dependent or independent of aldosterone. And so the way that occurs is that extracellular volume contraction stimulates renin, angiotensin, and aldosterone system, which increases circulating aldosterone. Aldosterone then stimulates ENaC in the cortical collecting duct and the connecting tubule, which stimulates sodium absorption, which carries through a positive charge. And once again, this mechanism depends on whether or not you're a Phil Steinmetz disciple or not. But anyway, it's thought to be that you generate a lumen-negative voltage, which provides a driving force for proton secretion. I actually don't believe that, but that's what they say. Okay. So it provides a driving force for K secretion and possibly proton secretion. I think it actually has more to do with the hypokalemia, which increases ammonia production. But anyway. And then under conditions where effective volume, vascular volume is reduced, the renin-angiotensin-aldosterone system is stimulated, which generates a metabolic alkalosis. So you can observe that in renal origin of the alkalosis, such as with diuretics, with Bartter syndrome, or with reduced salt intake or increased salt loss, like with diarrhea. And once again, we talked about the thick limb. NKCC2 mediates the absorption of sodium chloride. If you knock this out, you have a great loss of net salt absorption by the kidney. And then you can also get alkalosis with hypermineralic corticism, with volume expansion. High renin states can be seen with renal artery stenosis. So with renal artery stenosis, you get increased renin release, which ultimately stimulates angiotensin II and then aldosterone production. You can also get it in low renin states, like primary aldosteronism, when the adrenal gland is just making too much aldosterone, or with adrenal enzyme defects, or with other aldosterone analogs, like some types of licorice, chewing tobacco, or certain other drugs. You can see a metabolic alkalosis when aldosterone and angiotensin II are suppressed, which would be low renin states. And one good example of this is Little syndrome, where you have constitutive upregulation of the amiloride-sensitive sodium channel. So ENaC is always on the plasma membrane, and that's because the normal mechanisms of ENaC recycling are eliminated with this ENaC Little's mutation. And Little syndrome is autosomal recessive and occurs from truncation mutations in either the beta or the gamma subunits of ENaC. So with Little syndrome, what do you expect to see phenotypically? Remember, ENaC is always on the apical plasma membrane. It doesn't get endocytosed and degraded. So what do you expect to see?
They should be normal. I mean, they might have some kind of deafness or something.
Their hearing is fine.
Hypertensive.
They're hypertensive, exactly.
Yeah.
They're hypertensive and what else?
Hypokalemic.
Hypokalemic, right. Okay.
I thought you said phenotypically.
Yeah, phenotypically, yeah.
You know, I mean, I thought like appearance-wise. Shapes.
Well, I meant like symptoms.
Yeah.
Yeah. What are their problems?
Yeah.
So hypertension, hypokalemia, what else? Alkalosis, exactly. And how do you think you treat them? Yeah, right. Excellent. Okay. Renal origin independent of aldosterone, you can get it in a post-hypercapnic state. So in other words, if you have like a COPD, this should be renal origin. Maybe it is. Okay, so somebody who has a metabolic, who has emphysema, they run high CO2s, and then you suddenly put them on the vent, blow them down. The bicarbonate is going to be high because of renal compensation. Well, you blow them down, the bicarbonate's still going to be there, so they get a metabolic alkalosis. You can actually get it from hypercalcemia, like if you have some sort of demineralizing disease. You get the release of not only calcium, but also a lot of bone buffers, which, a lot of carbonate and stuff. You can get it from non-reabsorbable anions, such as some drugs, and you can also get it with potassium deficiency, which can trigger potassium deficiency, which can give you a metabolic alkalosis. So as I mentioned, the post-hypercapnic state, the chronic hypercapnia, which you see with emphysema, the kidney responds by increasing bicarbonate absorption. So the PCO2 and the bicarbonate are increased. but then if ventilation suddenly increases, like you put the patient on the vent, the CO2 falls, but the bicarbonate stays up there, so you get a metabolic alkalosis. Then with hypercalcemia, like which you can see during malignancy, you can generate a metabolic alkalosis because the bone, as a target for this cancer, not only releases calcium, but a lot of the bone vessels. And then you can also get it, of course, with non-reabsorbable anions and from magnesium deficiency. So metabolic alkalosis, this is just a tree of how you would work it up. So you want to first measure urine chloride. If it's low, you may have a chloride responsive alkalosis from one of these different defects, like diuretics, diarrhea, possibly post-hypercapnia, or a villus adenoma, so you want to just give them salt. If they have have a high urine chloride, then you want to measure their urine potassium or see if they're K depleted. So if it's low, they may be abusing laxatives, or they may. So you want to just give them potassium. It could also be due to diuretics over a long period of time. Then you also want to measure their blood pressure. If their blood pressure is normal, you want to think about Bartter syndrome or diabetic abuse. But if it's high, you want to think about renal. And then you can look at secondary causes of hypertension, like the aldosterone, workup, and so on and so forth. Okay, two cases. The first one's easy and the second one's hard. 80-year-old woman was brought to the emergency room for failure to fly. She lives in a nursing home and has dementia. So she pulled out her NG tube 3 days prior to seeing you, and she presented in the ER for placement of her feeding tube. Past medical history is unremarkable. Blood pressure is a little low. Heart rate's a little high. She's afebrile. She's cachectic. Dry mucous membranes and tinning of the skin. So she looks dry. Pulled out her feeding tube. Okay. White count is normal, hematocrite's high, potassium's a little high, sodium's high, bicarbonate's high, the BUN creatinine ratio is a little high, concentrated urine, everything else is negative, chest x-ray is negative. What's the first test you order? You're thinking about her metabolic alkalosis. Correct. And how would you treat her, the metabolic alkalosis? Right. And how about the hyperkalemia? Do you think that'll help? You increase the distal flow rate and also distal delivery of sodium.
So you're gonna waste more production then?
Yeah, correct. So you need to realize that flow rate stimulates K secretion independent of distal sodium delivery. Yeah. And people have asked, Lisa Satlin did that in the perfused tubule. So the fluid, the luminal sodium concentration remained stable, but she just varied the flow rate. Elegant set of studies, and K secretion really went up if you increase it.
There's a maxi K channel, right?
K secretion.
Well,
Which are flow dependent.
There is one signal that is stimulated. There is one signal that is stimulated and promotes.
Well, the sodium concentration in the luminal fluid stayed constant. All she varied was the rate. It either went real fast or real slow. And what I'm saying is the K secretion went up substantially with increased. Okay, excellent. Now this one's a little harder. 40-year-old woman was brought, this is a patient I actually saw at MD Anderson, was brought into the emergency room for weakness, fever, and shortness of breath. Past medical history is unremarkable. Once again, she was a little bit hypotensive, tachycardic, febrile, tachypneic. Physical exam was unremarkable, but she had a big spleen. A clue. White count, very, very high. Hematocrit was low. Platelet count was low. Very hypokalemic. That looks good. Okay, so what do you think is going on with her? Why was she hypokalemic? Oh, here's the other trick. Low urinary specific gravity. She could not concentrate her urine. Potassium in her urine, very high. Ooh. So what do you think is going on? This is a hard one.
So she's alkalotic, that's why
Right.
more ammoniogenesis,
Right.
and then
Why? Because she had more ammoniogenesis.
so you've got hypokalemia over there, and I guess due to alkalosis, I guess. Is that's the only driving factor over there?
I
and
think,
there's-
I think that the hypokalemia generated the alkalosis.
Okay. All right. And then less exchange. I mean, no, in the thick ascending gland.
Wait. Dr. Shrujita here has a good point, but you finish. And then I'll give her the floor. Shh, you need to be quiet. Okay, what else? So what do you think is causing the hypokalemia?
I'm not sure.
Okay, Dr. Shrujita.
I'm not 100% sure, but she had maybe the fact that the 200,000 white blood cell, like,
Do you know why?
I mean, I know you can get like the fictitious thing when their cell counts are very high, and it's actually hyperkalemia.
Yeah,
but
that's
now I'm
hyperkalemia.
wondering if it's no.
Okay, well, you're on the right track. It is her leukemia. But it's not been understood. I haven't reviewed this now in 15 years, but you get a kaleuresis with, you can get a kaleuresis with acute leukemia.
Okay.
And if you, and that is going to give you hypokalemia, and the hypokalemia is going to give you a metabolic alkalosis. So if you treat the hypokalemia, the alkalosis goes away. And then if you treat the acute leukemia, the K wasting goes away. So it's not understood. That may be a lysozymuria or something. Nobody knows why, but it can be seen with acute leukemias.
But typically speaking, like when I've gotten called about like stat labs or something that has come back with a high K, and we've attributed it to that when we check a plasma like versus a serum,
Pseudo?
there's a difference.
Right.
Do you know what I mean?
Right.
Right, it's
Pseudo-hyperkalemia.
Pseudo-hyperkalemia.
Yeah.
But I mean,
But this is
unless
due to
the difference-
kaleurisis, I guess.
Right, I guess I just don't understand the difference because I've seen it both ways.
Okay,
Maybe
this is a
acute-
different mechanism.
Okay,
So this has to do with, this is this is true hypokalemia.
okay, versus
And it's
the,
because the urine potassium, it's just inappropriate kaleuresis.
okay,
But why you get the inappropriate kaleuresis with a leukemia, I don't think anybody's explained.
okay.
Okay, excellent, okay. Okay, water metabolism, that's the last thing. So, yeah, so we won't need the full 2 hours. Besides, my voice is going to be okay, so water, just like sodium, you know, sort of nature, if it has a good model, it sort of reproduces it. So you get water absorption through 2 things that you need. First of all, you need the concentration gradient, just like sodium. And then you need an epithelia that's permeable to water. Just like with sodium, you've got to have, in the collecting duct, you've got to have a sodium gradient between the lumen and the inside of the cell, and the cell's got to be permeable to sodium. So the channel's got to be open and it's got to be in the membrane. Same thing here with water. You've got to have the concentration gradient, and you've got to have the epithelia that's permeable to water. Okay, so you do that by generation of a hypertonic medullary interstitium, which once again occurs through countercurrent multiplication. And then you've got to have a collecting duct that's permeable to water. So you have to have osmotic equilibration, the collecting duct urine, for the hypertonic interstitium. And you do that through the action of sodium water absorption through water channels or aquaporins. Okay, so the generation of hypertonic medullary interstitium countercurrent multiplication, that was actually first described in an elegant micropuncture study that was done by Carl Gottschalk, who was a nephrologist. Originally, the countercurrent multiplication was predicted by a bunch of Swiss chemists, and they predicted that you would have to have a single stage in order to concentrate the urine from like an osmolality of 290 to about 1200, which is what you see in people. Whereas some people, well, some critters like chinchillas can get their urine osmolality up to about 3000. Well, what these Swiss chemist guys who recognized is that you couldn't do it. It would require an infinite amount of energy if you did it at a single step. So what they predicted was that the kidney did it in a lot of little steps, and therefore you minimize the amount of energy. And that's indeed what the Milne and Gottschalk observed in micropuncture. So what they did was they punctured like the proximal tubule, luminal fluid, and then they took samples along the length of the loop of Henle and the collecting deck, and they found that urinary concentration gradually increased as you go from the superficial cortex down to the papillary tip, and then it fell again as you return to the cortex. So although this was predicted by the chemical industry, this was the first experimental evidence of that. And actually, nature makes use of it in more ways than just the kidney. And a good example of this is in the Antarctic penguin. So the penguin, stands around on ice all day. And so if its feet were at body temperature, 37, it would lose a whole lot of heat into the ice, and this is very bad. So heat conservation is really critically important. So the way the bird does that is that when the arterial blood leaves its core, which is at 37, it gradually transfers heat to the returning venous blood. So up here near the core, the arterial and the venous blood are going to be very close to 37. But then the temperature of the arterial blood gradually falls as it goes to the feet. And when it's at the feet, the temperature is just barely above freezing, or 0 degrees centigrade. Okay, so once again, this is the experimental proof this is the original paper by Gottschalk and Milne, who observed that plasma osmolality was 290, and then it gradually fell to about 1200 at the loop of Henle, and then it rose again to the papillary tip. It actually became hypotonic, as we mentioned, at in the early part of the distal convoluted tubule because of the action of the tri-transporter, although that had not been described back then. And then it once again becomes hypertonic as it reaches the final luminal fluid. And once again, the thick ascending limb is thought to be the single step for urinary concentrating ability. So it absorbs channels or the basolateral chloride channels. And once again, the manifestations of Barter's or salt wasting, hypokalemia, alkalosis, and defect in urinary concentration and dilution. Now, with psychogenic polydipsia, you have a washout of the medullary interstitium, and therefore you have an attenuated vasopressor response. So one distinguishing factor that you're trying to sort out somebody who has a true nephrogenic DI versus psychogenic polydipsia, is you can ask them what temperature of water they prefer. If they like room temperature water, or if it has to be cold, or if they don't care. What do you think would be the difference in response between psychogenic polydipsia and a true DI, central or nephrogenic?
The eye will prefer any temperature.
Who wants any temperature?
The DI.
Okay, what do you say? Who vote for the psychogenic polydipsia want colder water? Okay. How about the true DIs want colder water? Okay. You're right. And why do you think that would be? Because the thing is, people with true DIs are going to be constantly driven by thirst to drink water. I mean, their serum sodium is always going to be around 145, which is a level at which vasopressin is greatly stimulated. Well, so how do you reduce thirst? You can reduce thirst by two things, by drinking water, and the second thing is by temperature, because cold temperature is going to reduce thirst. So that can be a distinguishing factor. Okay, so the urinary concentration, you have to generate a hypertonic medullary interstitium, which you do counterpart multiplication, and then you also have to have a epithelium that's permeable to water. You would do that through aquaporin. So water is absorbed across renal epithelium either through paracellular transporters, pathways, or through water channels within renal cells. So this is the 3D structure of aquaporin 1. And it was first isolated and cloned by Peter Augrey, who got the Nobel Prize in 2003. Now, Peter is actually, what do you think Peter's background was? Okay, who says nephrology? Okay, who says endocrinology? Who says none of the above? He was a hematologist. And so it just goes to show you have to, go where the money is. So he was working on RH. No, I meant that scientific lighting. So he was working on RH proteins, and he was running a gel of something. I don't know what he was running. And he noticed a band in this gel that didn't seem to correspond with any of the RH proteins. So he was talking to a colleague, and a colleague said, well, it sounds like this might be a water channel. So we isolated the first water channel from red cells, which it turned out to be, we call now aquaporin 1. But it turned out to be much more important in kidney than in red cells, because the blood osmolality really doesn't vary that much in blood. I mean, let's be realistic. It's not that exciting in this context of hematology. But it's critical in renal nephrology. So most of his work is actually appreciated by the renal literature. So this is a 3D structure of aquaporin 1. So we're very proud of Peter, and this is what Peter did. So what he did was, these are red cells. And what he did was one had aquaporin 1 and one did not. And then he imposed an osmolality gradient. And of course, the water rushed into the one that expressed aquaporin 1 and the cell lysed, and this other one did not. So, and then here's Peter getting his Nobel Prize, yay. Okay, so then after Peter cloned the gene for aquaporin 1, all these other aquaporins were able to be cloned because their structure was not that different. But I think they're up to aquaporin 11 or something, I don't know. Anyway, they're up to a whole lot of them. The most important one, though, in the kidney from the perspective of concentrating ability is aquaporin 2. That is a major vasopressin sensitive water channel. So the only two that are really vasopressin sensitive are aquaporins 2 and 3. So we're going to focus mainly on aquaporin 2. Okay. So what happens when you knock out these transporters? So really, there have been a whole bunch of aquaporin knockout mice. And if you so what they did was they measured urine osmolality before and after water deprivation. This is 36 hours of water deprivation. I don't think they'd let you do that to a mouse anymore. I mean, Jeff Sands has a hard enough time getting them to let him do 24 hours. But anyway, they did 36 hours. This is a wild type mouse. This is normal mice. And so they measured urine osmolality, both, under basal conditions, and then they water deprived them for 36 hours. And you can see that urine osmolality went up to about 3,000 in a normal mouse after they've been severely water depleted. And then they did it in aquaporin 1 heterozygotes. And as you can see before, in the heterozygotes, if in other words, if they have one normal copy and one copy that's aquaporin 1 null, really they can concentrate their urine pretty well. But if they have both copies that are aquaporin 1, in other words, a complete aquaporin 1 knockout, they can't concentrate their urine worth a flip. So you water restrict them for 36 hours, and their urine osmolality hardly budges. Similarly, aquaporin 3, which is, aquaporin 2 is lethal. They just don't make it. But aquaporin 3, similarly, they have an impaired ability to concentrate their urine. Aquaporin 4 knockouts actually do pretty well. That's in kidney, but it's more interesting is it's expressed in brain, and there's a lot of interest in that as to whether or not knocking that out is protective against strokes, and I don't really know the mechanism, but that's what they say. Okay, so once again, aquaporin 2 is a main vasopressin sensitive water channel. And the short-term regulation, I did that, may I say, when I was a fellow. So what I did is I perfused the tubules from IMCDs of mice, and I measured water permeability before and then after the addition of vasopressin to the bath. and I found that you get that there's trafficking of aquaporin 2 to the apical membrane in response to aquaporin vasopressin that has a lag time of about 40 seconds. So short term, you have, in response to vasopressin, you have trafficking of aquaporin 2 from the subapical space to the apical plasma membrane, which increases in just more, results in more water being absorbed. But long term, like 2 days worth, you get synthesis of new aquaporin 2 water channels. And actually, a leader of mine, I was out on a trek with my favorite guide, and she asked me, she said, now Susan, why is it that when you first go on a trek, you're drinking water all the time, but then about 2 days into your trek, you don't seem to drink as much water? Well, when she first asked me that question, I had no idea. But then after Peter cloned the gene and March Knepper's group did all these studies, we know that more aquaporin 2 water channels are produced after about 2 days. So you really have stimulation of aquaporin 2, so you just don't have to drink as much water, because the kidneys kick in and really absorb it for you.
And they traffic from intracellular ER to the...
No. Well, ultimately, but the short term is just the subapical space. So they're hanging out there in vesicles waiting to be inserted upon demand. Yeah. I mean, ultimately, all proteins go through the ER, but that takes a little bit longer. So this is my experiment. Yay. As my first boss would say, you have to cite yourself at every possible opportunity. So anyway, this is what I did. So I measured osmotic water permeability, and under basal conditions, and then I added a vasopressin here at this point, because you can see that water permeability sort of chugs along at about the same rate for the first 40 seconds, and then it really takes off after that, and that correlates with the insertion of aquaporin 2 in the apical plasma membrane. Okay, so this is what happens. So aquaporin vasopressin attaches to the B2 receptor. That then activates adenyl cyclase, which increases cyclic AMP, which acts for protein kinase A, and then results in increased insertion of aquaporin 2 into the apical membrane. And so the long-term effect of vasopressin, once again, this has to do with the 2-day thing later, which my favorite guide asked me about. If you sample kidneys from mice or rats 2 days after they're given vasopressin, aquaporin 2 total protein expression goes up in tandem with increasing absorption of water. Okay, so the human equivalent of the aquaporin 2 knockout mice can be seen with an X-linked nephrogenic DI, a mutation of the V2 vasopressin receptor. So if you knock out the vasopressin 2 receptor, you get an X-linked nephrogenic DI. And then you also get it if you knock out the brain's ability to produce aquaporin 2. And so the central DI can be seen because, of course, vasopressin is not synthesized by the brain. And when that occurs, the expression of aquaporin 2 is very low. So aquaporin 2 protein abundance is going to be very low in patients with a central DI because they don't have the vasopressin to stimulate aquaporin 2 synthesis. The cause of a central DI, occasionally it's hereditary. That's rare, but it usually follows head trauma or disease of the hypothalamus or pituitary, or something surgical, like a hypothesectomy. And the treatment is just a vasopressin analog, so that's pretty simple. You can get a central DI that's either primary or idiopathic. As I mentioned, the secondary causes are head trauma, post-hypothesectomy, CNS tumors. You can get it with granulomas or with histiocytosis. You can get it with infections, with vascular disease. And then, of course, nephrogenic DI, you have normal production of vasopressin, but the collecting duct is unresponsive to the effect of vasopressin. And that can be inherited or acquired. I mentioned the inherited forms where we have a mutation in the V2 receptor, but you can also get acquired forms, and that the commonly seen acquired forms are the treatment with lithium, hypocalcemia, hypokalemia, which is why our patient with the acute leukemia had the dilute urine and a urinary tract obstruction. So this is data that was taken from Soren Nielsen and a variety of studies that he did. And what he did was, after thirsting animals, he measured their urinary flow rate, which of course was low, and he measured their aquaporin-2 expression. And what he found is that, of course, aquaporin-2 expression is high, following thirsting, which correlates with a reduced urine flow because water is being absorbed like crazy. So when you thirst, you increase aquaporin-2 expression in the kidney, and that results in increased water absorption, which reduces urinary flow. Now, in other experiments, he did the same thing, but he gave the mice lithium. And you can see here, aquaporin-2 expression goes down to about 5% of what it is in the normal healthy kidney. And because the aquaporin-2 is low, you don't get much water absorption, and so urinary flow rate is very high. And then he used other models like hypokalemia. Once again, aquaporin is reduced, which increases urine flow because water is not absorbed. And you get that to a similar degree with hypercalcemia and also obstruction. So the commonly seen clinically causes of nephrogenic DI are lithium treatment, which really gives you nephrogenic DI, hypokalemia, hypercalcemia, and obstruction. And so actually you can occasionally see a diagnosis of obstruction in the face of a negative ultrasound just because of a lack of urinary concentration. I actually did that. That happened to me once. So it doesn't happen very often, but about 10% of ultrasounds are going to miss, 10% of known obstruction are going to be missed by ultrasound. In other words, you're going to have obstruction, but what you see is a normal ultrasound. You won't see hydronephrosis. And I picked that up once. There was a man about 41 years old who had a T-cell lymphoma, large abdominal mass, and renal failure, which we couldn't explain. Because he hadn't gotten any nephrotoxic drugs, he was otherwise healthy, there was absolutely nothing on his setting, it was completely benign. But what is consistent in his renal ultrasound just showed this large tumor, but there was no hydronephrosis. So, but what piqued our interest was that he consistently had a very, very low urine osmolality. So we talked the urologist, I don't think the attending even heard about this guy. I talked the urology fellow into stenting him. So he did a cystoscopy, and he put in stents, and he told the patient, well, your urine output hasn't picked up, it didn't do any good. And then the fellow saw him, renal fellow, saw him like 2 hours later, and he had 2 liters of urine in swollen. And he was off dialysis 2 days later. Went down to a creatinine of about 0.7, so he completely recovered. He died of his disease, but with normal renal function.
Dr. Ross?
Yes, sir.
How about post-obstructive diuresis? You kind of get a DI, like hypernatremia, how urine flows after that.
Well, it's because if it's going to take a while for you to regain full urinary concentration. And see, if you're not making any urine, you're not going to get hypernatremia since you're not losing any water in your urine. But as you relieve the obstruction, you're going to be putting out massive amounts of water. And you can follow concentrating ability just by measuring serial urine osmolalities. But that's why you get it. So with normal ATM, you get you don't get marked hypernatremia. It shouldn't go above about 151. If you get somebody who has a serum sodium of 160 and you think they have recovering ATM, you need to think about something else. That's unusual for recovering ATM. Okay, so lithium, about 1 in 1,000 adults in the United States take lithium. About 20 to 30% have polyuria, and it's associated with a marked reduction in aquaporin-2 expression. You can get nephrogenic DI from inherited X-linked. It's the most common form of inherited nephrogenic DI. It results from the mutation of V2 vasopressin receptor. It's more common in men. You can also get a genetic defect in the aquaporin gene. It's autosomal recessive, but it's much less common. So, water deprivation test. How do you do that? Well, you withhold water, and then you measure urinary volume, urinary osmolality, and body weight at the beginning of the test, and then every hour. And then you check urine sodium and osmolality at baseline, and then every 2 hours. So when the urine osmolality should gradually go up. But then when it changes less than 30 milliosmoles per kilogram of water, per hour, or serum osmolality is greater than 295, which is when vasopressin release is maximally stimulated. You give vasopressin, and then you see what happens to urinary osmolality. I can tell you that with people who have true DI, they're miserable with this. It's so incredibly crazy. So interpretation, a normal kidney urine osmolality will rise with water deprivation, and when the endpoints are met, a vasopressin will have no effect since it's already maximally stimulated. But in DI, both central and nephrogenic will show little urinary concentrating ability with water deprivation, and in nephrogenic DI, vasopressin will have no effect, but in central DI, urine osmolality should increase more than 50%. Once again, you're not going to be able to completely increase urine osmolality to 1200 because they don't have the water channels that have been synthesized, and they probably don't have, so they're not going to be able to fully increase their, it's going to take a while before they regain full concentrating ability. Okay, so if you get increased production of aquaporin 2 and water retention during pregnancy and during CHF. So you can target, you wouldn't want to give V2 receptor agonist in pregnancy, but like tolvaptan has been used in congestive heart failure for hyponatremia. Now, to get hyponatremia with CHF, you've got to have a significant reduction in increase in the filling pressure. So if you just ligate coronary arteries without a significant increase in the filling pressure, you're not going to get the hyponatremia. But I think you have to be careful, and it's my feeling that tolvaptan and the other V2 receptor analogs probably change platelet function. Because, we give the vasopressin agonists to people before a biopsy, and it's to increase platelet function, and conversely, if you inhibit it, you probably attenuate at least transient platelet function. So I'm dying to get somebody to check a platelet function assay, over time when tolvaptan peaks, especially with somebody with sort of low platelet count.
But what receptors are they on the platelets?
Pardon?
What receptors are they on the platelets?
Well,
Are they aquaporin 2?
I think it's a type 1 vasopressin receptor. But I saw one patient, this was a woman with a platelet count of 50,000. She had bad congestive heart failure. She was young. She was not more than 45. And one of the surgeons gave her tolvaptan for her hyponatremia, which did correct it, but 4 hours after the tolvaptan, she had a major intracerebral bleed and ultimately died. So I'm just wondering if the tolvaptan compromised her platelet aggregation in the face of an already compromised platelet count, and she bled. So I think if you're going to do it, I think nobody studied that. I asked the manufacturer, and they said, oh, no, it's fine, blah, 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 blah. You don't need to worry about it with impaired liver function, but I think there's more going on. From a physiological standpoint, I think it makes sense that we need to worry about it.
And these patients are most often with aspirin.
What are you talking
Yeah,
about?
these patients are many times on aspirin because they're cardiac patients.
Oh, you're that patient?
The cardiac patients.
I don't remember that she was on aspirin. So that's it. Any questions? Okay.
Thank you.